warm welcome to MedCity News' Invest Digital Health Conference that we are running virtually. I am Arundhati Parmar, and I'm the editor-in-chief of MedCity News. As machine learning and artificial intelligence makes deeper inroad into healthcare, there are real dangers to be wary of. Used unwisely, they may hinder more than they help. Nowhere is this more important than in the issue of algorithmic bias. And that is the topic of our discussion today. So we will be discussing how to incorporate robust bioethics in AI algorithms. Our esteemed panelists are Sharona Hoffman, Professor of Law and Bioethics, Co-Director of Law Medicine Center at Case Western Reserve University School of Law. She will be our moderator. Erich Huang, Chief Science and Innovation Officer with Ondu, and Carol McCall, Chief Healthcare Analytics Officer with ClosedLoop. Sharona joined the faculty in 1999 and is now the Edgar A. Hahn Professor of Law, Professor of Bioethics, and co-director of the Law School's Law Medicine Center. She teaches health law courses, employment discrimination, and civil procedure, and was voted first-year Teacher of the Year in 2011, 2012, and 2019. She was elected to membership in the prestigious American Law Institute in 2017. Sharona has published over 60 articles and book chapters on health law and civil rights issues. She received her BA from Wellesley College, her JD from Harvard Law School, an LLM in health law from the University of Houston, and an SJD in health law from Case Western Reserve University School of Law. Welcome to you, Sharona. Next up is Erich Huang, Chief Science and Innovation Officer with Ondu by Verily. Erich was previously the Chief Data Officer for Quality at Duke Health, Director of Duke Forge, Director of Duke Crucible, and Assistant Dean for Biomedical Informatics for Duke University School of Medicine. There, he spearheaded and deployed machine learning capabilities for complex care management in Duke Health's Accountable Care Organization, helped develop Duke Health's new institutional governance process for algorithmic decision support, and helmed the creation of both the university's COVID core data repository supporting contact tracing and pool testing, and the School of Medicine's COVID integrated data repository for COVID research studies. Erich served as principal investigator on an NIH-funded project under the Big Data to Knowledge RFAs, and also served as the original faculty lead for informatics on Verily's baseline study. Welcome to you, Erich. Carol McCall is Chief Healthcare Analytics Officer with ClosedLoop. Carol has 30 years of experience as a health actuary and public health professional. She served as Chief Strategy and Product Officer for GNS Healthcare and as Chief Innovation Officer for Vanguard Health Systems. In roles at Humana, Carol led the Innovation Center's research, where the company pioneered Humana's use of sophisticated analytics to build a portfolio of predictive knowledge discovery and simulation models. She also launched Humana's personalized medicine innovations and led their health services research center. In policy and advisory roles, Carol served a 4-year term on the National Committee on Vital and Health Statistics and as co-chair of its quality work group, as a member of the HSRC's governing board, and as an advisor to the High-Risk Plaque Scientific Program Board. Welcome to you, Carol. Please take it away.
Welcome, everyone. It's a pleasure to be recording this program. We are going to be talking about algorithmic bias today, which is a really interesting and very important topic. And for anyone who is not completely familiar with it, algorithmic bias describes systematic and repeatable errors in computer systems that create unfair outcomes, such as privileging one group of users over others. So there's a really well-known case from Amazon, actually, where Amazon used an algorithm in order to try to identify job candidates that should be interviewed, whose resumes should be picked out of the pile. This algorithm, however, routinely selected males over females who were equally qualified. And that was because it had been trained using men's resumes. So it learned that men were good candidates and women were not. Algorithmic bias also occurs in medicine. For example, one algorithm was used to refer patients for high-risk care management programs, which are really beneficial supportive programs. But it favored white patients over African Americans, even though African American patients were even more likely to need the support for chronic diseases. And this algorithm did so because it relied on past medical expenditures as a proxy for medical need. So if you spent a lot of money in the past on your healthcare, it thought that you were sick and you needed this care management program. If you didn't spend a lot of money, it assumed that that was because you were healthy, you didn't need any support. But of course, African American patients often face access barriers, or they simply don't have money to spend on healthcare, even though they need it. And so this algorithm really exacerbated the problem by denying them the support and the resources that could have benefited them. So these are some examples of algorithmic bias. And Erich, I'm wondering if you could provide some other real-world examples of algorithmic bias in medicine.
Yeah, so I would even extend it further to say that in medicine, we have to assume bias exists everywhere. And so when we think about using algorithms in medicine, the Obermeyer publication that you mentioned regarding allocation of complex case management resources is probably one of the best illustrated examples. And I think it's reasonable to dig in a little bit into why we know it's biased, right? Because what that analysis did was it actually directly measured burden of disease as opposed to that proxy, which was healthcare utilization. So if you look at burden of disease, the cut point with which case management resources were allocated was tuned to Caucasians who actually have a lower burden of disease at that same cut point as African Americans. So if in theory we had used burden of disease as what we were looking at, that might have done a better job of reducing the potential bias in the system. But there are other sources, and I just want to call that out in that, for instance, there have been studies to show that pulse oximeters perform differently with people with different skin tones. Now, that per se is not an algorithm, though there's an algorithm behind a pulse oximeter. But what I'm saying is that the way we measure things is often going to be tied or confounded with some sort of bias. And therefore, I would say in medicine, we actually have to assume bias in the system. That doesn't mean we can't use it, but that does mean that we need to understand it, right? And the analog I would use is in medicine, we're used to the fact that certain drugs work better and certain other, one drug may work better in one person, it may not work as well in another person. And part of our job as clinicians is to go through a process to identify the best drug for that particular person. We may actually have to do that a lot with algorithms, and think of the algorithms as being somewhat similar to drugs as we think about in a sort of precision medicine context.
Right. I would love to ask almost a follow-up question for you, given your, the depth of your background. And aren't there actually algorithms, really kind of rules for clinical decision making? Aren't there ones that have corrections for race in them that have come more under scrutiny lately? In particular, like kidney care and transplants and things like that.
Yeah, and I think there's a lot of good intention behind that corrective process. But what I would argue then is we need to do a better job in first identifying possible sources of bias, because there's so many cases where we don't have any information to help us understand whether there's any bias, period.
Right.
And so what's lacking in the world of algorithms is that we don't have we're flying in the blind in many cases. And that what we need to do is we need to actually create processes that allow us to root out bias. And again, I would actually argue, since I assume all algorithms are biased, that we just need to make sure we apply them in an appropriate way. If we have a metric for glomerular filtration rate, for example, that that we actually understand that there's going to be performance characteristics that differ across different, racial or ethnic boundaries, and that we may need to use other measures to provide supportive evidence to allow us to actually do whatever clinical workflow that we need to do. I think the problem is we tend to sort of go under the fallacy of we look under the lamppost and, we have in the EGFR, so we're just going to use that. We need to develop other ways to measure, kidney function so that we actually have measures that actually are more appropriate for different groups.
Right.
Let me just clarify in case people are not familiar with those corrections. There are algorithms that will actually add points explicitly based on what race you are. So if you come in and you have certain abdominal pain, the algorithm will give you 3 points more or 3 points less based on your race in terms of diagnosing you as having kidney stones or some other disease. So they actually will very explicitly adjust based on race. And that's complicated because are they doing it based on what they think your race is, on how you self-identify? You might be of mixed race. There are all sorts of problems related to that. And of course, they all overgeneralize because it's not true for every individual that you're not likely to have kidney stones if you're of a particular ancestry.
Yeah, to this whole point, there was in New England Journal, there were a couple of articles within the last year that spoke to this very issue, which is how to think about the inclusion of race in any particular algorithm, whether it's an AI-based algorithm or some of these kind of earlier, more rules-based criteria and guidelines. And it was very, very useful. And they actually made a point of saying you need to ask and answer 3 questions. And the first one was the need to include race based on robust evidence or any sort of statistical analysis, right? And so if you couldn't point to some set of evidence, then you should really reconsider its inclusion. The second question they said was, is there a plausible causal mechanism for the inclusion of race? And I think that gets back to, Erich, some of the things you were talking about with respect to EGFR and some of the other things. Is there, in that evidence base, is there a reason to believe that there is a reason for including race that is causal? And a lot of biological mechanisms won't exist, but in population health, they may exist because of the evidence that, the social determinants of health would say that there's a robust body of evidence that structural racism as present is in fact causing and exacerbating, certain instances. So including it in those situations might be more justified. And then the third question that they said should be asked and answered is, would including race in a model relieve or exacerbate health inequities, right? And so if you answered those 3 questions in the process of beginning to examine some of the data, that can be a very helpful framework for making decisions about whether to include the actual variable of race or ethnicity in a model.
So Erich, are there different kinds of bias that you would describe?
Yeah, I think one way to start breaking apart this question of bias is actually to start give names to sources of bias. There's a really great publication by Friedman and Nussenbaum back in the 90s, and this is in I think it was in ACM transactions, and the way they classified it is this: is one form of bias is pre-existing bias. So what pre-existing bias is it's bias that has its roots, like we've been talking about, let's say in society and how institutions are built, societal and cultural practices. So you may build a system, and in this case, an algorithm that basically inherits the pre-existing biases surrounding us in society. So that's, as Carol alluded to, there may be social determinants of health that we just, we may include elements or variables that are highly correlated to social determinants, and those get incorporated into an algorithm and then essentially bring pre-existing bias to it. There are other sources of bias are technical bias. So technical bias can be basically attributed to how you designed your algorithm. So it's actually just the math in the algorithm. And if you just parameterize your model, which is, if you're looking at a linear equation, that's just assigning different, your coefficients. If you do it in a way that, injects some sort of bias technically, then that is a source of technical bias. And then finally, there's emergent bias. And that's something that especially worries me with algorithms in healthcare, in that, let's say you actually have done a good job in terms of developing an algorithm and really spent a lot of time in being thoughtful about pre-existing bias and addressing issues of technical bias, and you deploy your algorithm out in the wild. Well, let's say you deploy it in a health system, and your health system undergoes a really large merger, which significantly changes the underlying population characteristics of your patients. And that big change in the population characteristics actually changes the performance of your algorithm. And that's what we would call emergent bias. It's, the term for that is model drift, for example. So that's an example of emergent bias.
Yep. I think those are, I think that's one of those things where, as artificial intelligence algorithms in healthcare really begin to take hold, needs to be deeply appreciated. Just the idea that things drift over time. Data drifts, models drift, and bias sometimes creeps in, even if it was initially established that these things were fairly bias-free. Yeah, I think that's.
Do you have any concrete examples of any of these? Any good stories?
I would say that the issue of having significantly new patient populations come into an algorithm is definitely happened more times than we care to know about in algorithms in healthcare. And for the most part, they're unrecognized because, people haven't looked for it. So we know that it's a real phenomenon in the machine learning world. You can simulate that by, just injecting some change into, let's say, the population that you're testing, and you can see the performance characteristics of your model change. So the reason I'm not thinking of concrete examples is that there have not been enough studies of emergent bias out in the wild that there are public data about. I'd hate to say that, but we know in the methodological world, we absolutely know that this happens all the time.
So I've also heard the term algorithmic fairness. Is there a difference between algorithmic fairness and algorithmic bias?
Yeah, why don't I take that one, Erich? And maybe I can preface some of this by talking a little bit about the CMS AI Health Outcomes Challenge, which is where we had an opportunity to demonstrate my company's approach to both bias and fairness, and just kind of set the stage for that, and kind of put some of this in context. So about 2 years ago in 2019, CMS launched really kind of the X Prize for AI in healthcare. It was really kind of one of the largest contests, if you will, for all these companies to come in and kind of show their algorithmic prowess. And so entrants, entered to compete. And the goal was really to create these explainable AI solutions that clinicians could trust, and to predict health outcomes, of adverse events and unplanned hospital admissions and SNF admissions and other adverse events that doctors could use to kind of keep their patients healthy. And so there were more than 300, companies, kind of the best and brightest from around the globe kind of entered this thing. And through multiple stages, ultimately, they awarded the winner, and my company, it was really kind of a great story. We ended up winning the contest. relevant to this conversation is the idea that health equity was really at the heart of this particular challenge. And so in addition to the usual kind of algorithmic things where everybody stands up and talks about accuracy and area under the curve and precision, we also had to show how we would explain, the algorithms. And then the third part was the judges wanted to assess our ability to address issues of implicit algorithmic bias and fairness in our submissions. Actually, they asked us to address bias, and we addressed both bias and fairness. And so to do this, what we did was we applied a really comprehensive framework from Paulus and Kent. And this was a framework that they laid out, say basically, here's how you go about assessing bias and fairness in the development of these algorithms. And so to our knowledge, it's the first ever application of this comprehensive framework to do exactly what we're talking about here today in models built off of the CMS Medicare data. So it was a really kind of large case study, if you will. And part of that, we also developed and applied a new fairness measure. And so it's a metric called group benefit equality. And so we developed that and we applied it throughout this study to kind of show whether and the extent to which algorithms that we were developing, if applied, would they be fair or unfair, right? And so part of this was actually in this framework, Paulus and Kent distinguished between bias and fairness. And so what they said was bias really relates to what Erich was talking about before. It's really surrounding the technical aspects. So how a model is designed, the data that is used, the quality of that data, is that data representative? And so what you're doing is you're ultimately going to assess the extent to which a subgroup, some subpopulation, is disproportionately affected by the performance of the model, right? Now, fairness is less about those aspects, and it's really more about how the algorithm is being used and what sorts of decisions are being made by it. So in the case that you talked about, Sharona, at the very beginning of these algorithms, which were actually created by Optum, that were kind of on a systematic basis prioritizing whites ahead of blacks in terms of care management and outreach. That would be an example of, yes, there was a certain kind of bias, but it was leading to an unfairness. And the unfairness was that whites were always getting to the front of the line, and it wasn't really related to their observed needs, when those observed needs, with respect to their actual health, would have had far more blacks enrolled and prioritized than was actually taking place. So that really distinguishes between the idea of fairness, from the algorithms that help, generate that.
So how can you measure whether bias exists? What do you do?
Well, there's several things that you actually need to do to measure whether bias exists. And so what you can do, part of it is there's some great work out of by Zayed and his team, Obermeyer, coming out of Chicago Booth. And they actually have created a playbook, an entire playbook for how you can go about assessing the extent to which, bias exists. And you have to begin by looking at, is your data, first of all, is it representative, right, of the population, in the context in which this is going to be used? And so you have to understand your data quality, you have to understand your data representativeness, and there are tests that you can run to look at that. And so that was, one of the first steps that we actually did. The next thing that you have to do is you need to evaluate the performance of the model, with respect to these subgroups, and you need to look for evidence of where it might creep in with respect to the features or the variables that you are actually creating from that data to build the models. And are those features also representative or not? Are your features diverse or not? And how are those differences actually affecting the performance of the model? There's another thing that you need to look for when you think about different types of bias. There's a lens that the folks in Chicago use, and they talk about subgroup invalidity and what's called label choice bias. And so subgroup invalidity, that can happen when your model performance is disproportionately affecting a particular group because of this model design or the data or the sampling issues. But this other type of bias called label choice bias is, again, the example you were talking about earlier, when there's a proxy. When you've picked a variable, you have actually selected a variable to predict that is not the actual thing you're interested in, but you've chosen a proxy. And in that case, they chose healthcare costs as the proxy for someone's actual healthcare needs, right? And there's a whole bunch of reasons why costs go up and down that are completely unrelated to health. And so when you pick a label that is a proxy, the problem is that it's very difficult to detect. Accuracy, in other words, is not a reliable predictor of label choice bias because the bias is built into the actual label itself, right? And so that's why it tends to go undetected so often. It also, unfortunately, turns out that that is the most prevalent type of bias. And at the end of the day, label choice bias is not something that you can automate the detection of. So label choice bias actually begins in the design by people, by humans, of the algorithms. And so one of the most important things to mitigate, bias in algorithms is actually setting out and clearly understanding the labels that we are choosing to predict. And what the folks at Chicago Booth would recommend is actually coming up with multiple different endpoints and trying to triangulate your way in and test an experiment, if you will, with different ways to represent the thing that you're actually trying to predict.
I agree with Carol that this labeling bias is probably one of the most difficult things that we have to deal with in healthcare, because a lot of the things that we're trying to predict actually don't really have a gold standard sort of objective clinical test to them. Mm-hmm. Or just that the state of our data is relatively poor, so we can't actually get directly at what we're trying to get. So with the Optum algorithm that we were talking about, they use utilization as a surrogate, right, for the need for getting healthcare services, rather than measuring that need directly. And Obermeyer's group actually did a good job, and it's like, if we're looking at hypertension, let's actually look at directly measured hypertension instead. And the problem with healthcare is that there are two, you think about diagnosis codes. Well, are diagnosis codes truly representative of the pathophysiology of disease in a patient? No, they are billing codes. So there may be bias in those labels because we may steer to certain billing codes, systematically because they reimburse better. So, there's a lot of that bias in healthcare data, partly because it's so siloed. It often doesn't measure directly what you want to measure. And that is definitely one of my biggest fears, because you may exquisitely target that wrong label. You may do a fantastic job building your model to that right label, but it's that wrong label, but it's not the right measurement of the outcome that you're trying to achieve.
Right. And another example, even in the CMS contest, was obviously we tested as many subgroups for bias as we could, and yet some of those subgroups weren't available that we would want to test, weren't available in the data at all, right? So you can't test it. An example was that data did not have veterans in it. The VA was not part of the limited data set coming out of the CMS 5% samples. But it also used race and ethnicity as a combined classification. You're like, really? Okay. All right. Well, that is what it is. And so you're kind of stuck with that, but that's not, the way that you would ideally want to do those things. And so there are limitations to the data that we have that we would do very well to always be vigilant, about looking at. There are limitations all around. But what I would say is that the thing that we brought as a part of our submission was essentially showing the importance of explainability, right? And so what we mean by explainability is just is simply put, is kind of moving away from giving these simple risk scores to people, right? Whether it's a label of high, medium, low risk, or if it's simply a number. And instead, what we want and need, and we're able to demonstrate, is being able to quantify the very specific risk factors that were used by the algorithm that gave rise to any particular score. And what it does is it gives, kind of visibility into the inner workings of these algorithms. And so you can see how they're designed, what they're doing, why they are producing the answers that they are, so that you can examine them, right? Because at the end of the day, I mean, value-based care and the achievement of sustainable solutions in value-based care are going to rely more and more on algorithms. And so the problem is that if we get those algorithms wrong, if they are biased, it will actually make the problems that we face today worse, and actually then better. Teams that are going out there trying to, accelerate health equity will find themselves actually exacerbating it as opposed to helping it. And so we have to insist on AI solutions that are completely transparent, deeply explainable, and completely traceable and auditable, so that we can look at them not just today, but over time, so that they raise their hand if they are in fact drifting off course from what you originally set it out to be. And so hopefully
go back to something. Sorry, I want to go back to something that Erich mentioned very briefly. Is it possible that bias will arise because of financial incentives in healthcare?
Can you give me an example of what you mean by that?
Well, he mentioned that you might choose labels, et cetera, because of billing, for example, because you might make more money if you call it this rather than that. And I'm wondering if you think that's a real problem that could give rise to bias.
I think it is something that you always have to be cautious of, right? Because I think part of the intent, let's say, of value-based medicine, as Carol was talking about, is we want to align the reimbursement process with actually good outcomes, right? And the problem with volume-based fee-for-service medicine is those can be going in different directions. Your
Right.
profit motive can be malaligned with actually, providing better health to your patients, and hence the cases that we're seeing of, cardiologists doing paid-for immunovalue procedures on people who don't need them because they knew they could, really reimburse well on those procedures, and they're not indicated, and so obviously those patients did not really benefit from those procedures. So I do think it's strange enough that we're talking more about health policy, but I actually think you can't, in the end, you can't separate policy from these kinds of discussions.
Right.
Is that I actually do think, yes, there is a danger of financial incentives, changing sort of the design motivations, either insidiously or frankly intentionally. But if we do create a framework in which the financial motivations are aligned with what's good for your patients, that becomes less of a problem. And it's funny because I was at a policy conference in DC where we're presenting artificial intelligence to policymakers. And one of the people in the audience asked me, so what technologically do we need to get in healthcare to really get this going? And I said, it's actually not technology, it's actually value-based reimbursement. That will actually help us build the algorithms the way we need to build them, and actually have the incentive to build algorithms that actually help our patients get better.
I agree wholeheartedly. And to your point, Sharona, your question, I would say that the incentives are already, they've been baked into healthcare, not by design, but by default. Just volume-based reimbursement bakes in an incentive to provide care, not necessarily, consistent with always delivering value. And so that's the big turning of the ship that we have right now. But you can already see that it changes people's attention. Business models matter. If you tell me how you get paid, I'll tell you what you care about every day, because you have to, right? And so we're going to make it economically rational for people to care about health equity. And when you see, everybody's focus now on the social determinants of health is so much bigger than it was 10 years ago. right? And which is wonderful. And the reason is that it's not that people all of a sudden woke up to this idea. It's that all of a sudden they're now able to do the things that they've really known about and cared about for quite some time. It now becomes rational to care about all of the things that determine my health, not just the medical care that I get. And the more that we're able to, instantiate these alternate payment models, the better, except for one thing. If we don't pay attention to algorithmic bias right now, we're going to get it wrong. Because algorithmic bias, if everybody goes out and builds algorithms kind of like the Optum one, then we're going to fail, because it's going to put the white folks ahead of the black folks in line every single time, and that's not going to work. It's going to exacerbate these already unacceptable disparities. But the good news is, and the experts say, that even though it's pervasive, it's not inevitable. That we actually, and so this is a technology solution. Don't buy anything that can't explain itself. Don't buy anything that is just a black box. So that when you sit down to design algorithms, Erich, you are owed a set of explanations coming out of that machine before you implement anything.
Is that realistic though? Because I thought a lot of algorithms really are pretty much black box, where even the designers don't fully understand how they work. So is it realistic to expect explainability in every case?
I believe that it is. And the reason I say that is because that's the heart of what we do where I work. And that's why we won the contest, right? And so I can't speak for other companies and what they produce, but I can speak for what we produce. And the way that our platform was built was to build everything so that everything that goes in and comes out is completely transparent and audible and explainable. And so I know that the math exists to do it. Some algorithms, they are held as proprietary. And so that's somebody's piece of secret sauce. It's not that they can't explain it, but it's that if they reveal that magic to everybody else, then there goes their business, right? And so I think that ends up being a company choice as opposed to a technological constraint.
So
yeah, Sharona.
Oh, I'm sorry. Go ahead, Erich.
I just want to elaborate on that too, because, obviously people say, if I have like, an 1,000-layer, convolutional neural network, how do I explain that? And I agree with Carol that we shouldn't let people off the hook from that. In right. That now you can't, honestly, yes, you can't explain all of that, but what you can do is you can provide insight into that machine, into what's going on. You can essentially build in sort of the sensitivity analyses so that people can understand sort of the where it hits its limit and where it doesn't. And you can provide sort of essentially proxies for what that model is paying attention
right.
to.
Yep.
So, I mean, there's going to be depending on the type of methodology someone uses, there'll probably be different routes, what I would say, to understandability or explainability. But, I do think that it's appropriate to lay the burden of proof on the people who create the algorithm to do that. And I also do think that from a regulatory standpoint, the regulators need to, even if we're giving some level of proprietary, trade secrets to the builders of an algorithm, the regulators should have access to
yes.
That information.
Right.
So yeah, I mean, there's a big discussion that can arise from that, but right. I agree that with Carol that we should really be pretty relentless in asking for what this means when an algorithm produces a result.
Right. And I think, to the point of it, algorithms don't need to lay themselves out to the world, but they do need, there's so many places in business where we sign statements and we attest to the fact that we have shown this and audited that. And so maybe the transparency is with the regulator, or the transparency is in some sort of oversight relationship. So it's not to the world, but it is, in something. I think it's reasonable for us as these technologies advance, we sometimes get so swept up in what they're capable of. And what we forget to ask is what we should demand from them, especially if they are going to live in service to helping us do certain things. And so I think this is one of those areas where we need to accelerate into a very clear set of policies around what we should expect of these technologies and the users of the technologies to do as best practice, and to be able to attest to as having followed during this process of using them.
That was very well said. So we've talked a lot about race bias. I just want to bring up, there can also be gender bias, right? So I've read, for example, women have different symptoms of heart attacks from men. And if you build an algorithm, but it's trained on records from male patients, it's not going to get it right because it's going to ignore the symptoms that women more typically have. Have you encountered those kind of gender bias problems as well?
Can you think of an example, Erich?
Medicine's full of exactly those examples. I'm not familiar with any concrete examples of an algorithm performing that, but because, as you know, a lot of that's baked into the data, that's actually one of my worries, in that a lot of the people who build the algorithms are people who haven't worked in healthcare. Those things, Sharona, that you described, that's like one of the clinical pearls that you learn early on as a medical student, when you do your internal medicine rotation. But a machine learning methodologist doesn't go to med school and doesn't learn those clinical pearls. So I can't think of specific examples, but those kinds of examples of gender bias or any other sorts of bias that we sort of anecdotally know about, and clinical pearls are almost by definition anecdotal, but passed on from generation to generation. Those are things that I am concerned about. So definitely one of the concerns I have then is, do the people who are building the algorithms know healthcare well enough to be building algorithms in a healthcare setting? That's a big question.
Right.
So they don't routinely work together with physicians or healthcare experts?
They do, but I'm not sure the knowledge transfer is always complete, right? I having done this before, I get a sense that sometimes the clinicians are a little bit bright-eyed and like, oh wow, this is cool.
Right.
The algorithm builders are likewise feel the same way. It's like, oh, I'm going to be solving this great clinical problem, and they immediately get very reductionistic in
Right.
terms of looking at things. And so I do have concerns, and I think this maybe is a historical artifact in that there are not enough clinicians who've been trained in sort of data science yet to be sort of the right sort of ambassador of clinical knowledge to the data science world, and not enough data scientists who've had clinical experiences either. I've actually proposed that, Duke, for example, my previous institution, that we actually have data scientists do clinical rotations, partly because of this question.
Right. I think it is right now, the disciplines have historically been fairly far apart. What I do see happening in kind of the AI industry is that there is recognition of what you're talking about. And so more and more, there's an appetite for vertical AI, that basically to do it well, you really need to have a subject matter expertise, kind of literally woven into the fabric of what it is that you're building. And so part of the way that we approach that at ClosedLoop is that we have two pillars of technology, and one of them is the math. It's the data science platform, end-to-end, purpose-built, goes from data through to deployment on models. But the other is this library. It's an enterprise feature store that's nothing but clinical content, right? And so it creates all of these embedded clinical features for what to calculate and how to calculate that. That is not left up to a data scientist sitting back there building the algorithms, right? And then when you combine that with explainability, so that when you sit down with, before you ever deploy anything, and the clinicians who are going to use it to help make decisions, they actually get to sit and push on this thing and go, I don't understand that, right? Why did this thing produce that prediction? Because when I look at the variables here, I don't get it. You know, we seem to be missing something here. And so, and maybe there's more features or more diversity or different feature sets need to be brought in. And so I think there's a whole conversation and dialogue that the tools need to enable, and I think can be augmented by what you're talking about, Erich, which is go further back upstream into the education process itself, you know, and create it as an expectation if you're going to come into the discipline. Yeah.
So if you figure out that your algorithm is biased, what do you do? How do you fix it?
You want to take that, or you want me to go first, Erich?
There's no single fix, right? We've already talked about lots of things where you can, as Obermeyer talked about in his framework, you can look at the data, you can look at the variables and these kinds of things. So those certainly represent some fixes. I also think that just like, put it this way. So if you go into the operating room and you have a right-handed surgeon, they have trays for right-handed surgeons. They also have trays for left-handed surgeons. And of course, there are fewer of those trays because there tend to be fewer left-handers. And there are also surgeons who are left-handed who've just gotten expert at using right-handed tools. I'm using that anecdote because there is an occasion to think about, well, if I know this algorithm is biased in this particular space, but I know that its performance characteristics are satisfactory if I narrow that space in which I use it. That's another approach to using the algorithm. Just like, if I know ACE inhibitors, some of my patients, won't do well with an ACE inhibitor. Doesn't mean I throw out ACE inhibitors as a medication for hypertension. Just means that I'll try to confine the use of ACE inhibitors to those to whom they respond and don't have side effects.
Right.
So it's then what do we need to know is we need to know what the side effect profile of an algorithm is, so that we can try to avoid using it in populations with whom those side effects are detrimental.
Right. Or I can add on to that by sharing a little bit of what we do. Going back to Obermeyer's work, if most things are due to label choice bias, one of them would be, is there any other label that you can pick, right, that would reduce that? And I think the researchers, I think it was ProPublica, actually came through and picked a different endpoint for the Optum algorithm and reduced bias by like 84%. I mean, it was just like an amazing, just like pick another variable, right? Unplanned hospital admissions or avoidable admissions or something, and you can do something that way. Another thing would be to look at the mix of variables that are being used, and maybe you have some variables in there that are tipping it one way or another. But the third would be back to this group benefit equality, this fairness measure. One of the reasons that we developed it was that some of the other fairness measures are just completely inappropriate to healthcare, right? Like disparate impact, I think, is the one where it makes this, which is used a lot in, I think, labor law. And it makes an assumption that is fine in other situations, but in healthcare is completely inappropriate, which is that everybody has the same, rate of the event. So, for example, that it would assume that men and women have the same rate of breast cancer. All right, then. Well, we don't. But because it makes that assumption, it would then only judge algorithms that's fair if we got the same rate of mammograms. They go, well, that's inappropriate too, right? So what we developed was this measure that did a better job of saying, look, we're going to have different rates, and some of them are going to be appropriate and expected. And then at other times, it's going to be the very thing under scrutiny, like rate of pregnancy-related adverse events, race-related adverse events in pregnancy. The side benefit of this approach was that it allows you, if you have remaining bias in your algorithms, to adjust your program and adjust the enrollment rates for your program so that you can adjust it so it is more fair. Because it quantifies the degree to which your algorithms are unfair if used to make certain types of decisions. So, for example, if you have a program that enrolls the top 5% of people, right? 5% of people at risk for an adverse event, and you do that across the board, and you realize that is going to end up being unfair to African Americans or Asians, and you can adjust that enrollment threshold, and it'll tell you exactly by how much, so that you are actually enrolling people in proportion to their observed need. And so that's why we created that thing, because if you can make all those other adjustments and you still have some remaining bias that would result in unfair decisions, you can then adjust your enrollment thresholds to adjust for that. And that would be, our recommendation. And if none of that works, Obermeyer and companies say, then don't implement it. Then don't use it, right? You're just going to make things worse. You're not helping.
So you've talked a lot about labels. Does somebody want to define what a label is in this context?
Really a data science term for the outcome or the endpoint that you are actually trying to predict. It's as simple as that. It's the thing that you are trying to train your model to recognize.
So concretely, when you go onto a website and it gives you that reCAPTCHA thing where it says, click all the tiles that have a car in it. That's basically someone asking you to label the data for you, right?
Yeah.
And they're obviously doing this across many hundreds of thousands of people or millions of people, and they're getting they're sort of crowdsourcing, the best quality label for that. And that's again one of the things that we really have difficulty with in medicine is
right.
saying this is a diabetic, right? Because you ask 10 clinicians, if someone is with a set of clinical characteristics as a diabetic, you'll probably get some variability.
Right.
And we don't understand that well enough.
Right, and sometimes it's a moving target too, right? So what we think of as a diabetic today, even if we all agreed, that definition might change based on some discovery 5 years from now. And so this whole thing is a lather, rinse, repeat.
Yeah. So hypertension. Hypertension is a good example. We move, our categories of hypertension around, and we've done that quite recently. If you use those categories as sort of the way you built your model, let's say use the deprecated categories, then you'll be off, in the modern world. And so that's where then you should then directly use the blood pressure measurement as opposed to use the assigned category.
Right.
So that's where, model, that label choice is almost an art. We like to say we're data scientists, but it's actually, there's an art to that selection.
Yeah.
So do users have some responsibility to look for bias and identify it and go back to developers and demand change, or is it really all at the development stage, do you think?
I think, as a clinician, I would say part of our professional obligation is to always, consider whether the thing that we're using, whether it's a surgical instrument or an algorithm, is performing the way we want it to perform. I think that's part of our professional obligation. One thing at Duke that we've done is we're starting to stand up a committee that actually specifically evaluates algorithms, and not only evaluates them at the initial gate to deploy, but also to revisit those algorithms over time. And so I do think that I honestly think that should be a thing that all health systems do if they are going to use algorithms, is to do that reinspection process. Just like if a surgical stapler misfires, I'm gonna call the manufacturer.
Right. Yeah, I think that there's it's part of the oath that you take as a physician, right, as a clinician, kind of a do no harm, and because of that, there's an obligation. to know the power of what it is that you're using and the limitations of that, right? I do think, though, that there needs to be something, if I'm a clinician, there needs to be some process, some good housekeeping seal of approval, right? That if you can trust that seal, that you can pick that thing up and use it today, right? And you may want to regularly come back and make sure that all those seals are still, because things drift over time. So, but yeah, I think that there needs to be a process that things are subjected to before they are ever used in the first place.
Yeah, I totally agree. And to use an anecdote that not with algorithms, but is I think informative of this is, I was talking about machine learning with a bunch of surgical residents at Duke. And then it occurred to me, so then I asked them, do you guys know how serum sodium is calculated? And honestly, I don't remember how serum sodium is calculated. I'm not actually even sure I ever learned it. And neither did the residents. And now we know, I can go into Wikipedia and find out how that's calculated, and it makes sense. But the reason why those residents, when they are rounding on their patients that morning and pull up their blood chemistries and can feel confident in that sodium, is that there are an array of good housekeeping seals of approval from CMS, the FDA, a whole realm of regulatory, approval of the processes that led to that result. We don't have that in machine learning right now. So I agree, is we need a regulatory framework that allows us to at least, know that the quality of the thing that's being presented to us, this algorithm, has met, some sort of regulatory, level. And that, again, that doesn't mean we're not obligated to pay attention to it and use it well, but that does allow us to operate with a lot more sort of confidence in the algorithm.
Right. Yeah, I also think, and this is all very early days in this, I could imagine that a framework might come forth that even puts it into different types of tiers or something, for lack of a better term. Almost, when you start thinking about different types of devices and things like that, they go through different kind of tranches of approval. And I think it depends on how the algorithms are in fact being used, right? Kind of the degree of scrutiny that is going to be applied, but I think they all will end up needing to be, scrutinized in some way, or, what do we all learn in math class? Show your work. That's what the teacher always said. So, and I think all algorithms are going to have to, stand in front of the teacher and kind of show their work, right? And I think what's going to change is who are they showing it to, right? But everybody's going to have to show their stuff.
So to what extent does the FDA regulate algorithms? Do you know? I believe it does regulate some of them, to some extent at least.
Yeah, so the framework that exists right now, and there's still really guidance as opposed to actual regulation, is that algorithms are going to be treated in like medical devices. So there's this term SAMD, software as a medical device. And just like we were talking about previously, there are gradations of the risk level with which an algorithm is trying to accomplish a clinical result. So if you had an algorithm that's going to identify the chemotherapy a cancer patient is going to receive, that's at a much higher risk level and a much higher level of scrutiny than, let's say, something that's providing you, an estimate of your heart rate while you're working out. So there is guidance out there. The FDA is still thinking through how it wants to regulate algorithms, and there's a lot of discussion going on in terms of how it's going to do that. But I would say that I do think that it needs to come under some, it can't be unregulated.
Right.
There's too much at stake.
Right.
Should it be regulated just like devices, in your opinion, or differently?
I think, for what it's worth, because of existing frameworks, at the FDA sit under devices, and devices obviously have embedded, software in them, that it's a pragmatic approach to the problem. I do think that ultimately, we need to evaluate whether we should think of an algorithm as discrete as a device. But I think for the moment, that is a workable thing for us to work with until we sort of get to a better state with, the state of the art when it comes to algorithms.
Right. It's a good starting point. I would agree. I think ultimately, as we know more about them, and what they're capable of, and are able to articulate what we want from them, I think that framework as a starting point will be able to add to it, and in some of the different ways in which algorithms are being applied. When I think about, in a way, that the revolution that's taking place here is going to be, it's probably going to be even bigger ultimately than the impact of the internet itself, right? And so there's just so much that we don't know about, the extent to which these things are going to get woven into the fabric of everything, right? But as Kevin Kelly says, it's what technology wants, and it's going to happen. And so we can't imagine, as we sit here, all the different things that we're going to need to be able to speak to. So I think starting with what we know works well, and then adding on as we learn more it's the only way that we can go. So yeah, we just have to be ready to respond to the good, the bad, and the ugly of what we see happening. What we need is a regulatory framework that is fairly agile, as well as honest and earnest. So that would be my hope.
Yeah, it's interesting. If you are hurt by an algorithm, there isn't that much recourse. We do have anti-discrimination laws, such as Title VI of the Civil Rights Act and Section 1557 of the Affordable Care Act, which prohibit discrimination in healthcare. But they don't clearly provide individuals a right of action. It's usually up to the government to enforce those anti-discrimination mandates. And Carol, you mentioned disparate impact previously, and that is relevant here because presumably a doctor would be using an algorithm, and the algorithm, although facially neutral and the doctor is using it in good faith, it ends up hurting African Americans or women or some other group. So that is called disparate impact. It's a facially neutral tool that has a different impact on members of a protected classification. So there are laws that address that problem, but they generally do not provide a private cause of action for individuals. It's up to government enforcement, which is a problem if you got a wrong diagnosis or suffered some catastrophic result because of a decision made by an algorithm. So is it too scary to use these algorithms for healthcare decisions? How should we move forward at this point?
I think, as Carol alluded to, I think algorithms are going to be an important part of healthcare if used well. Now, that's easy to say and actually hard to do, right? I will say that one of the things that we need to start with is the data, right? I think methodologically, we've got a pretty enormous armamentarium of methods with which to, model and predict. What we don't really have is high quality data in healthcare that allows us to make those label choices in a judicious way, for example, right, or that allow us to sort of try to separate structural bias from the underlying data. So one thing I would argue is that in order for us to get to algorithms, we need better data in healthcare. Right. We need, and one of the big problems too is that because data is so non-interoperable, despite 21st Century Cures Act. And of course, those regulatory components only were put in the Federal Register last year. That lack of interoperability makes it hard to actually do that evaluation, right? Because you sort of build these bespoke algorithms based on bespoke data sets that, which makes it hard to scrutinize them and actually do that peer review process to say, you know what, it's an easy exercise for me to take this algorithm and now just sort of snap it onto my health system and just do a sort of silent run-in test and see how it looks. That interoperability doesn't exist. It takes so much time and labor to sort of get an algorithm running in your health system built somewhere else. So I would argue that when it comes down to it, the fundamentals, which is data quality, data interoperability, are going to be important. I'm not going to say exclusively important. They're necessary, but not sufficient for better algorithms.
Right. I think to add on to that, first of all, I would agree that the data and the quality of it, and just how liquid is it, right? And then what is the quality of that liquid? I do think that that's changing, but I think it has been late, and it's been late to love your family, by the way. So cute. Healthcare has lagged behind, so we're this kind of laggard industry, but I think that is starting to change, and I think that the tsunami of data, but more specifically, healthcare becoming digitized finally, is going to change some of that. And I think even some of the laws around interoperability, they're going to be forcing functions for each other. So I do think that the data, which has mostly been burden, I think we're going to go from burden to bonanza over probably the next 5-ish years, and because of that, I'm actually fairly hopeful about AI. I actually don't think it's a question of whether or not AI is going to come. It is going to come, and I actually think that we need it in order to sustain value-based care. Right? We are reaching a tipping point. I mean, we're at a crisis of affordability and access and equity that we have got to solve. Value-based care can help solve it, and you need algorithms to do it, and they have to be unbiased. So giddy up. But to that point, I think that algorithms with the methodologies we've been talking about today actually can help reduce bias. Because I think, Sharona, your question about, should we be, fearful of what may be unleashed, there's already tremendous bias in healthcare. It's literally baked into how we deliver care every day, is already incredibly biased, and yet we really have no way to examine that. And so what I'm looking forward to, if we insist on it from our technologies, is a big bright light that helps us understand in a way that's more, not only just explainable, but changeable, right? So now all of a sudden, if you're sitting around with your colleagues, your clinical colleagues and your data science colleagues, you go, man, I had no idea. Okay, we can adjust this, that, and the other, and we will have a less bias, delivery mechanism. And you'd be like, I'm all for it. I never knew, right? It reminds me of, a decade ago, and Atul Gawande wrote that kind of now famous article about McCall, Texas. And what was amazing about that article, about, I think it was a cost conundrum. And McCall at the time was the second highest cost Medicare, county or city in the country. And when he went there, what he learned was that it wasn't that the people in McCall were trying to, pull something over on anybody. When he shared the data, it's that they actually had no idea. They had no idea. They couldn't see the forest for the trees. And then they're like, wow. And so the system does what it does. Our system actually isn't broken. It's actually just poorly designed. And so if we want different outcomes, then we have to redesign it. And I think the kind of transparency that we're talking about now, kind of layered in and woven in with value-based care, can help us redesign it much more intentionally. And so that's what I'm really hopeful for.
So is part of the problem right now electronic health records, which often are of poor quality with lots of missing data and mistyped things? And and so on. Do we need to improve electronic health records before we're going to get really good training data?
The electronic health records are definitely imperfect vessels, but they're a symptom, right? And as Carol alluded to, the way healthcare in the United States is constructed, you sort of get what, that's a consequence of what we have. So, one thing I argue, and I've written about this, is that to get better EHRs, we actually need to change the motivations of healthcare delivery, right? Because EHRs have been designed mostly for optimizing, reimbursement, and not really, even though they carry that name, it almost feels like it's secondary that they're vessels for storing high quality health information.
Right.
Yeah, if it's about billing codes and stuff like that, fine. And so what we really need to do is rethink, what do we want from an EHR? Let's build it foundationally up from, let's build the best quality record of patient information so that we can, do shine really bright lights of data science tools on those data. And right now, the business motivations of EHR vendors are to actually prevent that, right? And in fact, they try to keep people out of the EHR because they worry that, one, they'll expose a lot of the data deficiencies. Two, they want to figure out how to monetize algorithms themselves and make that sort of a easy, smooth channel for them to market them, make it harder for other people. So it's a design problem, but part of that design problem is the fact is that we have, as Carol alluded to, not a broken system, but a poorly designed system in general in healthcare.
Right.
So we have only about 5 minutes left. Is there anything we didn't cover or any other points you want to raise?
Want to go first, Dr. Erich?
Yeah, it's funny, and it's been gratifying that this discussion that's not only about algorithmic bias is really addressing sort of the entirety of healthcare policy and
we did cover a lot, right? We've solved it all.
Right. And again, I reinforce the fact is, from a data standpoint, data are reflective of the motivations behind them. And those motivations can be sort of fee-for-service driven. They can be motivations that, are basically representations of the social, constructs that we have. And so what I would say is that if you focus too much on just fixing the algorithms, then you don't focus on what do we really need to fix, which are a lot of structural things in the way we deliver healthcare. So it is almost impossible to escape having that bigger discussion, even if you're talking about how do we, use algorithms in healthcare. And so I'm glad, Sharona, you've let us seemingly digress into all that space, because I think that's important.
Right. Yeah. Thank you as well. I guess I would say that, I talked earlier about healthcare being kind of a laggard, and in many ways we just get dragged kicking and screaming into so much new technology, right? And yet, healthcare is complicated and also complex in ways that other industries are not. And with all the highly specialized resources and deep knowledge that are required, to come together, it's much more balkanized than other things that are in more the consumer realm. And the stakes are higher too, right? Let's be honest. And so in that respect, it's not so much that AI is late, but maybe AI is finally ready, right? It's grown up enough, that we can start to think about how it can be leveraged, to good in healthcare. And so it's not perfect. I think it's ready enough. And I think it's ready enough for the things that you're talking about, Erich, which are, it's time for the leaders of healthcare organizations to really begin to consider not just the technical aspects of this, because that's only part of it. Flip the coin over and what it is that we need to do in terms of people and process, in addition to technologies, to make these things work for us. And so, I think there are several things that I think we need to do, and we've talked about many of them, but I think we need to strive to start to demand certain things of our technologies, right? So show your work, right? If it's math, show your work, but also include very diverse stakeholders in the process of the design and that good housekeeping seal of approval, which you can do internally before anybody comes knocking on the door, right? And to always be assessing these things on a regular basis. They could start out great, but always kind of be looking at them. And to explicitly evaluate them for their potential impact, not just on bias, but fairness. How are these things going to get used? When you use them in a sentence, what kinds of decisions are you making? And are you looking to, kind of allocate scarce resources, and is everybody going to get a share in accordance with their observed need or whatnot? And last, we haven't really talked about this, but be willing to share those results with certain, other stakeholders, maybe not on the website, but maybe with, kind of diverse committees and standing committees, and perhaps with, kind of external regulators as well. Yeah.
Well, thank you so much. This was a terrific discussion. I certainly learned a lot. I hope the audience will learn a lot, and I really appreciate your taking the time to be with us.
Thanks for today. Thanks, Sharona. Thanks, Dr.
Thank you,
Erich.
Sharona.
That was a fascinating discussion. Thank you so much to all the panelists. I was particularly struck by the element of emergent bias, and that you could start thoughtfully without pre-existing or technical bias, but your models may drift and you end up with bias creeping in nonetheless. With so many hospital mergers happening, this is totally possible and something to really watch out for. So again, thank you to the panelists for such a fascinating discussion. I learned a lot.